Good evening, everyone. Good evening, ladies and gentlemen. Can you hear me?
We can hear you, Julie. Hope you can hear me.
Yes, Julie, we hear you. And yes, Vera, we hear you.
Thank you, Eric.
Can anyone hear me?
Yes, we can.
Good evening, everyone. Karibuni sana to yet another time that we can have a webinar. This is the Breast Cancer Awareness Month, and we are here to get more information, to enlighten ourselves and to update ourselves on issues breast cancer. I'm happy we are all here. We are able to log in and are eager to learn. This evening, we have a lot of information to be shared by our doctors. Some of them, most of them are things we have had, but we are here to get the latest updates. We have a talk on the overview of breast cancer management. We also have a talk on breast cancer screening, which includes imaging, early diagnosis, among other things. So I want to welcome all of you. I will also request that if you have a question, please put it on the wall, the Q&A wall, so that we are able to communicate appropriately. So to start us off, we have Dr. Eric Hungu, who is a breast cancer and general surgeon at the Kenyatta National Hospital. Dr. Hungu is going to talk to us about breast cancer, the overview. And karibu sana, Dr. Hungu. I know you have a wealth of information and we are here waiting to learn. Welcome.
Thank you, Julie. I hope you can see my screen.
Yes, we can. Yes, we can.
Okay, so thank you for inviting me to give this talk. I'll try to keep it brief because we have two other speakers. So this is just an outline of what I'm going to be talking about today. So I'm just going to give an overview of the global burden of cancer and the economic impact. And then because in this Breast Cancer Awareness Month, and I'm a breast surgeon, so I'll go straight into the topic at hand. So there'll be some introduction. We'll talk about the risk factors. We'll go into clinical presentation, staging tests, rationale and goal of screening, but I won't dwell on that because the radiology team is going to talk about that. And then we'll go into the management, an overview of management. So clinical evaluation, diagnosis and treatment, and what level of care is expected at various healthcare levels, and what is our role as healthcare providers. So just as a preamble, it's been documented and it's been shown that the burden of cancer is rising globally. And this is causing a significant strain on populations and on the health systems at all income levels. And somehow, from the documented information that we have, majority of these cancers occur in the low and middle income countries. And the situation is not looking to get any better. It looks like the cases are going to rise by about 70% over the next 2 decades, with significant economic effects. So in 2010, data from WHO showed that the economic impact directly and indirectly came to $1.16 trillion. So you can imagine, if you just try to translate that to our local setup, by the time someone is coming to us and we make a diagnosis of cancer, even before we start on treatment, we are talking about tens of thousands of shillings. And that person is missing work and they don't come to hospital alone. So their immediate relatives and their friends, they're also accompanying them to work, which translates to also a loss of income, and that has a significant impact. So locally, after infectious diseases and cardiovascular diseases, we find that cancer is the 3rd leading cause of death. And that next bullet is just a list of cancers in no particular order by incidence in both genders. So there's cervical cancer, there's breast cancer, there's esophageal cancer, there's prostate cancer, and there's colorectal cancer. And overall, esophageal cancer was the leading cause of death, followed closely by cervical cancer and breast cancer. Unfortunately, in our setup, 70 to 80% of cancer patients are diagnosed at an advanced stage. That's stage 3, stage 4 disease. And that's partly why we are having these webinars in this month of October, so that we are able to raise awareness amongst health workers, so that we have a high index of suspicion when someone comes to us in our facilities, so that we don't miss or delay their diagnosis. So in view of such data, the Ministry of Health under the National Cancer Control Program and the National Cancer Institute developed the National Cancer Screening Guidelines, whose main focus was on the prevention, early detection, and cancer screening. So going to breast cancer, locally, it's the leading type of cancer by incidence, and you can see there's a significant increase in cases between 2018 and 2020. So in 2018, there were 5,985 new cases diagnosed. And in 2020, there were 6,799. And that translated also to higher death rates. So 2,553 in 2018. This went up to 3,107 in 2020. And if you look at the literature, so most of the textbooks that we study when in medical school, of course, are written in the West. And in the West, they show that breast cancer, the incidence, the age group, the demographics is usually the older people. So from age 50 going up, and they've tailored their screening guidelines into those age groups. But looking at our demographics, we find that it affects women earlier, so between age 35 and 45. And you can see that 70% are diagnosed with stage 3, stage 4 disease. So what are the risk factors for developing breast cancer? So like you've seen locally, the age group is lower, and then race and ethnicity. So if you look at the literature, we talk about ladies of African-American descent being more predisposed to developing breast cancer. When you talk about sex, or to be politically correct, you talk about gender. So if you're female, then you're at a higher risk of getting breast cancer. So that's not to say that men cannot get it. Men do get breast cancer, but the incidence is usually about 1%. We also talk about family history. So we can categorize population into either high risk or average risk. So you fall into high risk category if you have a family history of breast cancer. And by family history, we talk about first-degree relatives, like 1 or 2 first-degree relatives who've been diagnosed with either breast or ovarian cancer. There's also radiation, and radiation is a question that we get asked a lot by patients. So those patients who've done a little bit of research, a little bit of reading, when they ask, when you say that radiation is a risk factor for developing breast cancer, what do you mean? So it's not walking out in the sun, or when you go for your annual mammogram and you're exposed to that radiation, that's not what we say is a risk factor. So the risk factor is people who got radiation therapy as treatment for head and neck tumors that can predispose to developing breast cancer. Another risk factor is estrogen exposure. So we talk about the age at menarche, age at menopause, use of estrogen-containing contraceptives. So those are the risk factors that we analyze when you're talking about estrogen exposure. And then lifestyle. So if it's a sedentary lifestyle that you lead, so that means that your BMI can go up, and going back to physiology, conversion, so that also sort of like translates to estrogen exposure, because in higher BMI in postmenopausal women, peripheral fat is converted into estrogen, and that can lead to increased estrogen exposure, leading to a risk of getting breast cancer. And then breast density. In ladies whose breast tissue is pretty dense, there's an increased risk of developing breast cancer. So how do these patients present to us in our clinics or in our outpatients? So bullet number one, we talk about no lump, just a screen detected lesion. We don't see a lot of those, at least not in the public setup. This is more common in populations where screening mammography is common, so that at your annual screening, you detect lesions on the screen, but on clinical examination, no palpable lumps. So that's not very common in our local setup. But hopefully when we embrace early screening, this will be something that we get more and more of. And then the most common presentation for our population is patients coming to us with a lump. And usually this lump is painless. It is progressive. It's usually slowly progressive. Sometimes they can come with nipple discharge, and nipple discharge is a bloody nipple discharge is the commonest presentation for breast cancer. Pain is not very common, but if someone comes to you with locally advanced disease, maybe the lump has progressed, it's ulcerated, and then it might get secondary infection, and then that can cause pain. So when you talk about orange-like breast skin, that's what we call the pod orange. So that can either be involvement of the skin by the breast cancer, or there's edema because of the size of the tumor. So that edema affecting the skin, and then you get that dimpling, and it looks like an orange peel. The next bullet is talking about the ulceration. Now, talking about broken bones or bone pain, that will be someone presenting to us with stage 4 disease, which is metastatic disease. And this would be metastasis to the bones. So when you get bone met, then you get pathological fractures, and that might be the first presentation for the patient in hospital. Axillary adenopathy is pretty common, considering most of our patients come with stage 3, stage 4 disease. And someone coming to us with cough or difficulty in breathing. So this is something that you might pick up with your patients when they come to the clinic, and you need to be very keen, because I've noticed it in a few of our patients. So someone comes, they tell you that they've had a breast lump, but as you're talking to them, as you're taking a history, you need to be very keen, because you might notice someone now is getting breathless, or they have a persistent cough. So when you further interrogate that presentation, then you might be able to pick up maybe there's someone who's coming to us with advanced disease, with metastatic disease, with pleural effusion. So this is just a table demonstrating the stages of breast cancer. So when you talk about stage 0 disease, that is someone who has come to us with carcinoma in situ. So that's what that means, not going beyond the basement membrane. And then stage 1 is someone with a lump, the disease might have gone to the local nodes, the axillary lymph nodes, or might not have gone. So you have stage 1 or stage 2. And then, stage 1A or stage 1B. And then stage 2, there's a lump with palpable adenopathy. Stage 3 might be involving now the skin anteriorly or the chest wall. And then stage 4 is someone who has distant metastasis. And the stage at presentation has an impact on survival. So looking at that graph, people who present with a later stage, that's T4 disease, that's the lower line. You can see the survival rate is low. So that is pretty much the reason why we try to encourage screening for breast cancer, so that when you get early detection, potentially it's a curable disease, or at least the patient will get to live longer. And that's basically why that's the next slide, the rationale and the goal of screening, so that you can detect it early, in early stages, that improves prognosis, reduces mortality. So as per the guidelines that the Ministry of Health has developed, and also which is in line with global guidelines and recommendations, mammography is the recommended method of screening for women in the average risk population. So we'll talk about remember we talked about the high risk versus the average risk population. So in the average risk, mammography, and mammography is done as per age group and as per the national guidelines, from age 40 to 55, do screening mammograms annually. Then from age 55 to 75, you do screening every 2 years. And then from age 75 is as per discussion with your patients. So some patients opt not to continue with their screening, but in my experience, even the ladies who get to age 55 and you tell them you can do this every 2 years, they still opt to continue with annual screening. And that, again, we do not discourage. As per patient preference, we can continue with annual screening, regardless of the age group. So this is just an image showing a mammogram. This is I think this is a CC view. Dr. Manduku will correct me. But you can look at the image on the left. That's the old images. So technology has evolved. So now the quality of images we get is pretty high. So on the left is an analog mammo, and on the right is a digital mammogram. So you can see when we look at the mammogram, so I don't want to dig into Dr. Manduku's talk, but you usually look at the skin, the nipple, the breast tissue, and you can see the definition on the image on the right is much higher than the image on the left. And it's important when you're telling your patients to be going for this annual screening, they need to go with their most recent mammogram. So if it's a mammogram from last year, they need to go with it, so that if anything was detected at that mammo, and they do a follow-up mammo, if they see anything or they look at that previous lesion that was noted, then they can comment, has it progressed, has it changed, are there any architectural changes or distortions? So going into management, just an overview, this is going to be a broad discussion. So we're going to talk about the clinical evaluation, diagnosis and treatment. There's a care at various levels and our role as providers. So when you talk about evaluation, so we need to go into history. So this is the basics that we are taught in medical school. So the basics don't change. The only thing that changes is what technology is available to us. And you can see the image from the previous slide, the previous analog mammograms versus current digital mammograms gives you better definition in terms of imaging. But our basics in terms of clinical acumen, so in terms of taking history and in terms of clinical examination, that does not change. So in history, you need to think about the risk factors and you need to elicit that history when you're talking to the patient. So we're talking about a family history of a breast or ovarian cancer, or a positive BRCA gene test in a first-degree relative. And then we need to look at the reproductive history. So all these things need to be documented in the notes. So we are talking about the estrogen exposure. So those were the things I talked about earlier. The nulliparity, age at menarche and age at menopause, the menstrual cycle, history of not breastfeeding, whether the patient has been on hormone replacement therapy or not, age at first delivery, contraceptive history, and you need to define which type of contraception, whether it's an estrogen containing pill or not. And then if there's a previous history of an abnormal biopsy. And history of irradiation, that's in terms of treatment with chest wall irradiation and lifestyle. So in the history and in the clinical examination, and in the clinical notes from the examination, it's important to just note the patient's BMI because it gives us an indication of their risk level. And also when it comes to treatment, it also has an impact. So when it comes to examination, so these are the things you look for. So sometimes there might be an obvious lump. The skin is dimpling. You remember we talked about the pod orange. Then sometimes there might be some change in the skin color or texture. So in some types of breast cancer, there might be no obvious lump, but it might present as a change in the skin color or the texture. So I'm thinking about inflammatory breast carcinoma, in which even if you palpate, so it might present with erythematous skin. So looking at it, you'd think it's an infection, but like I said, you just need to have a very high index of suspicion and just do due diligence in these patients. So some patients might also present with changes in the nipple appearance. So you might have nipple retraction. And that's why when you're examining these patients, you must always just expose the torso so that you compare both sides. So then your examination is not complete if you do not try to see if there's any discharge from the nipple. So in physical examination, you document the BMI. It's also important to assess the performance status. And by performance status, you're talking about are they able to carry out their activities of daily living? So in KNH, as part of our flagship form, we have developed a template because this is a lot of information to assess for. But if you have a template where you just tick as appropriate, then the chances of you forgetting some things are lower. So the performance status, it determines how sick this patient is, whether from the cancer, whether it's metastatic or not, or from their comorbidities. Because if the patient is elderly, they might come to you with other issues like diabetes or cardiac failure. And this also has an impact on the management plan or your treatment plan for this particular patient. And then you look out for the signs that I mentioned in the previous slide. And as you're documenting, it's very important to mention, and if you're able to illustrate, just mention the tumor location, the size, talk about the symmetry or asymmetry of the breast, talk about whether it's involving the skin or the chest wall. So that would mean whether it's the difference between a T1 to a T4 lesion. And then it's also important to document whether the regional lymph nodes are involved. And by regional lymph nodes, we're talking about the axillary lymph nodes. And it's also important to assess the cervical lymph nodes. So supraclavicular lymph nodes, it's important to assess those because it also gives us an idea of the burden of disease. The examination is not complete until you assess and examine the opposite breast. It's not uncommon to have someone coming to you complaining of a lump on one side. But when you do an examination, you find a lump on the contralateral breast. And that also carries through to your imaging. Currently, I don't think there's any imaging center in the country that will only image one breast. But previously, some years ago, guys would only image the breast that has the problem. But nowadays, it's good practice, and it's a standard operating protocol to just image both breasts. You might pick up an occult disease on the contralateral breast. And then once you're done with your local examination, it's important to conduct and complete the physical examination, assess all systems in case there are any comorbidities. So this just demonstrates how to do a clinical breast exam. So this is this slide shows the palpation sequence. But of course, before you palpate, you need to inspect the patient, and we inspect the patient while they are standing or seated on the couch. So when you're inspecting, you're trying to see whether there's symmetry or asymmetry. You're looking for any obvious skin changes, any obvious masses, whether there's any nipple retraction or not. And then you ask the patient to raise their arms or maybe to lean forward. You want to see if there's any fixity of the breast to the chest wall. And then now you palpate. So different people have different methods of palpating. So depends on what works for you, but the recommendation, you can go circular motions and then just be systematic. If you start on the outer quadrant, just make sure you go, if you're going clockwise or anti-clockwise, just make sure wherever you start, you must finish there. You inspect the axillary tail, palpate the axilla for any nodes, and at the nipple areola complex, you express to see if there's any discharge from the nipple. And you palpate with the pads of your fingers, so that's more accurate. You're able to get a better definition of whether there's a lump or not. So once you've done your clinical examination, clinical breast examination, the next thing to do is to send the patient for imaging. So here the slide talks about if someone is over 35 years, you do mammogram, and below 35, you do an ultrasound. So this is true for diagnostic mammograms as opposed to screening mammograms. So you can do a mammogram on a patient who's 35 years going above, but below, that's usually debatable. But that's for the diagnostic. For screening mammograms, the current national guidelines talk about starting screening mammograms at age 40. So if someone is younger than 35, sometimes you get patients in their 20s, or someone who falls into the high risk category. And by the national guidelines, someone who's in the high risk category, I think you start screening. If the patient, their relative who was diagnosed with breast cancer, let's say was diagnosed at 35, you start their screening 10 years before that. So you start their screening at 25. Now at 25, an ultrasound might not be able to give you all the information you need. A mammogram is not appropriate because of the higher breast density in the young ladies. So for such patients, a breast MRI is indicated, but that is a decision that needs to be made by the surgeon or the breast surgeon in consultation, of course, with the radiologist. And once you have requested this imaging test, decision is made on these images based on the scans delivered and a report from a qualified radiologist. If you find something suspicious, then you need to biopsy. If the suspicious lesion is in the lymph nodes, the axillary lymph nodes, then an FNA would be adequate for that. But for the primary lesion, that's the one in the breast, FNA is just to give you an idea, but you make a diagnosis based on a core needle biopsy because you get more tissue and you're able to run further tests on the tissue you get from a core needle biopsy sample. So I won't dwell too much on this. Dr. Manduku is going to talk about this, but I just need to point out the BIRADS category 0. I've noticed it causes quite some confusion, even amongst our colleagues. So when you see a report that's come to you and it says it's a BIRADS 0, do not reassure the patient that everything is okay, that they can go home and come back after a year. No, BIRADS 0 means that you need to do further imaging, that the imaging that we've done or the imaging that was requested was inadequate, so that if it's an ultrasound, maybe, if it's a mammogram, maybe the breast tissue was very dense and we are not able to make a conclusive decision whether there is anything suspicious. So in such a case, you'll notice that the radiologist will recommend some additional imaging, either an ultrasound or an MRI. And then there are the other BIRADS categories, depending on what is seen on imaging. So to sum all that up, For patients coming to you with a breast lump, the most important thing to remember is triple assessment. And triple assessment means you've taken a history and done a clinical examination, a thorough clinical examination. Then you've sent the patient for imaging, the appropriate imaging as per their age. And then you need tissue to make a diagnosis. And for the breast, remember we said it's a core needle biopsy. You also need to get a diagnosis of the lymph nodes. So if there are any suspicious lymph nodes, the ultrasound or the mammogram will document that. And then when you go for biopsy, you can do an ultrasound guided biopsy of the lump and an ultrasound guided biopsy or FNA of the axillary lymph nodes so that we get a proper TNM staging of the breast lump. So this is just an algorithm talking about how you manage patients with breast lumps as per BIRADS category. So I won't dwell too much on that. Suffice it to say that if you come across a lump, clinically you feel a lump, on imaging you find a lump, it's always appropriate to get some tissue diagnosis for completion of your assessment. So talking about the pathology, when you do the core biopsy, so first it will tell you whether it's a malignancy or not. And if it's a malignancy, it will tell you which type of malignancy, whether it's a ductal carcinoma or whether it's a lobular carcinoma. And then the additional tests that we usually request for that have an impact on management are the immunohistochemistry tests. So that's looking at the receptor status. So we usually ask for the estrogen receptor, progesterone receptor, human epidermal growth factor receptor, in short HER2. And then there's an additional test we ask in the immunohistochemistry. It shows the growth index of the tumor cells. That's the Ki-67. So some labs don't do that, but it's usually nice to have that because it helps us to further categorize the tumor biology that we have. If the patient has an abnormal nipple discharge, you can do a nipple discharge cytology. You do an FNA of the axillary lymph nodes. And all these tests must have a report signed out by a qualified pathologist. And you can see in that box there in pink, which is in keeping with our theme for breast cancer, decision to treat a breast mass should not be based on the FNA alone. You need to do a core biopsy. FNA is complementary when you do the axillary lymph node FNA. So these other lab tests, just some supplementary lab tests before you take your patient for further treatment. So the hemogram, urea electrolytes and creatinine, LFTs, HIV test. This is important if you're going to take your patient either to theater or if your patient is going to get chemotherapy. The other tests, not mandatory, but they might provide some useful information. For instance, the alkaline phosphatase. If you're suspecting someone has some bone metastases and you're waiting for your imaging, or if you get a report, an imaging report that says that they see some lesions on the spine or on some bones, and they're not sure whether they are metastatic or not. Sometimes an alkaline phosphatase might give you an idea, because if it's a metastatic lesion in the bones, that means it's a lytic lesion. Then you might find that the level of alkaline phosphatase in the blood is raised. So that is an additional test that you might consider. The personalized test, the BRCA testing, the Oncotype DX, and the Mama Print, these are individualized tests. They are not readily available in all the labs, but they are available in some labs in Nairobi. These are tests that further give us further information on a particular individual when it comes to choice of giving chemotherapy. So it gives us more options for personalized treatment. But I think they should not be requested routinely. And for the most part, they are out of reach for majority of our patients. And these are the staging considerations before treatment, not necessarily preoperative. whether you're going to start with upfront surgery or you're going to start with chemotherapy, all your patients must be staged appropriately from your clinical examination and from imaging. So when you talk about staging, we're talking about T staging. So T is talking about the tumor. That's the primary lesion. So you need to, from your initial examination, you need to document whether this tumor is a T1 tumor, T2, T3, or a T4 tumor. And you also document on the contralateral breast. So when you send this patient for imaging as well, the imaging test also measures the size of the lesion. So that gives us a more accurate assessment of the T stage. And then, of course, if the patient goes for surgery on the pathological specimen, the pathologist actually measures the actual dimension of the tumor. So the end staging for the nodes. So remember, we talked about assessing the axillary nodes, assessing the supraclavicular nodes, and on imaging, the radiologist also tells us we see there's some enlarged axillary lymph nodes. They even give you the dimensions. They talk about the architectural distortion in the lymph nodes. And then once you've done the surgery, you've done the mastectomy or breast conserving surgery, and you've done your axillary surgery as well, pathology actually counts the number of nodes that have been harvested, and they tell you out of the total number of nodes harvested, X number had metastases. And they even go further to classify the metastases. Is it microscopic metastases, or had the tumor spread beyond the cortex of the lymph nodes, which would make it macrometastases. And then the end staging is only determined on imaging. So for all our patients, we usually send them for staging scans. So per national guidelines, if the tumor is T2 and below, a chest X-ray and an abdominal ultrasound is sufficient. If it's locally advanced at a T3 or a T4, then we do the CT scan, the CT of the chest and abdomen. As you do the CT chest abdomen, you get a comment on the pelvic structures and you get a comment on the bones. If it's not conclusive on the bones, you can further request a bone scan. If you think that the patient might have a disease in other organs, like if a patient comes to you with breast primary but complaining of headaches or seizures, then you can ask for additional investigation, for instance, a CT scan of the head. Once we've made a diagnosis of breast cancer, the SOPs dictate that all new cancer patients must be discussed at a multidisciplinary team. So this has become easier, of course, with COVID, because now we've learned that you can have these discussions online, either on Zoom platform or Google Meet. And the core members of this multidisciplinary team, there needs to be, if your facility has a breast surgeon, the breast surgeon needs to be in that meeting. If there's no breast surgeon, then a general surgeon needs to be there. You need a radiologist, you need a pathologist, you need an oncologist, you need a nurse, palliative care, social worker, and you need an MDT coordinator to help with the documentation, because sometimes this can get to be quite a lot of work. So you need someone to do overall coordination. There are other subspecialties, other disciplines that are important that maybe we've not talked about here. Maybe an obsgyny in case your patient is pregnant or is in the childbearing age and they want to preserve fertility. You talk about a plastic surgeon, you can talk about a nutritionist. But managing cancer patients is not done by individuals. It needs to be a team discussing. So remember, we talked about subtyping invasive breast cancer. So that's when the immunohistochemistry comes about. It's important in guiding us in terms of prognosis, in terms of prediction to treatment, response to treatment. So now we have this current subtype of breast cancer. So when you talk about luminal disease, it can either be luminal A or luminal B disease, but luminal disease broadly are patients whose immunohistochemistry comes back as hormone receptor positive. So the ER and PR are positive. Now, luminal A versus luminal B, you now take a look at the HER2 and the Ki67, and it will tell you which category the disease falls into. then there's and this determines treatment because these are patients who can respond to endocrine therapy. So that means you can give them after you've done with your surgery, radiotherapy. These are patients who can be put on follow-up with either tamoxifen or letrozole or anastrozole. So then you have HER2 enriched patients. So the hormone receptors are negative, but the HER2 receptor is positive. So this is someone who will benefit from Herceptin treatment. And then now you get the basal-like, which is what we call triple negative disease. So the triple negative disease has traditionally been shown to be more aggressive, but it responds pretty well to chemo. The luminal disease, the response to chemo is usually not as good, but it still responds to chemo. So if you get a luminal patient and the tumor is operable, you can actually start with upfront surgery if it's amenable to upfront surgery. So this is just an algorithm about managing these breast cancer patients. And these are your management options. So broadly, we talk about the management options for breast cancer patients falls into surgery, chemotherapy, radiotherapy, hormonal therapy, this biological therapy, and then this supportive therapy. So as per the stage you're coming into, you can either get some or all of the treatment options. But again, like we said, these are decisions to be made by the multidisciplinary team. And at the various health facility levels we are at, this is what is expected. So at a level 1, so across all levels, we expect the healthcare workers to promote breast health awareness. So that means when the patients come to your clinic or to your outpatient, they need to be told about breast health awareness. And by breast health awareness, we're talking about giving them information about doing breast self-examination. They need to come for annual screening. And if they feel that there's something different in their breast, on their self-breast examination, even if it's not time for them to come for their annual screening scan, they can still come to hospital and get a consultation and get a clinical breast examination and then be guided as appropriate. But then at level 2, 3 hospitals, then you take that further to doing a proper, detailed clinical evaluation and then refer patients onwards if you have a suspicion that this is something more sinister. And then at level 4, 5, and at tertiary level, then all these things should be available, including surgical, so diagnostics in terms of imaging and pathology and surgery. And there should be MDTs, whether on site or virtual. Now with the Zoom platforms, we have regional, at least for the breast malignancies, we have regional breast MDTs. So there's one in Nairobi, there's one in the Western region. I think there's one in Coast Province. So all these things all these are resources that we can tap into. And then at level 5, level 6, if you have a plastic surgeon, then you can start talking about reconstructive options for your patients. So this is the role that we play as healthcare workers. We need to educate our clients at any opportunity you get, whether they're coming for a gyne clinic, whether they're coming to the surgical clinic, whether they're bringing their child for follow-up for antenatal, or whether they're coming for antenatal, whether they're bringing their child, because sometimes they might come for a pediatric clinic and then they tell you, as a by the way, that they have a problem in their breast, might be mastitis, but you take any opportunity that you get to educate them on self-breast examination and the importance of early screening. And you tell them to go home and tell a friend. And you need to have a high index of suspicion so that you can identify those who are at risk. And once you do that, you need to take a thorough history, do a thorough physical examination, and refer as appropriate. So this brings me to the end of my talk. Those are my references. And I'm sure there will be questions at the end, but I stand guided by the moderator. Thank you.
Wow, thank you so much, Dr. Hungu. That was a lot of information, and we are grateful for the information that you have shared. there is a lot to take home from your talk. Among them is that age in our session, patients who have breast cancer, who are being diagnosed with breast cancer, are even at a lower age than globally in Kenya. So that is something that we need to also take care of, take concern about. Without much further ado, I want to invite our next guest. Our next guest is Dr. Veronica Manduku. She's a research scientist and Deputy Director, Kenya Medical Research Institute, which is the Center for Clinical Research. Dr. Veronica Manduku, please feel welcome and share with us what you have for us. Karibu. Daktari, we can't hear you.
Are you able to see my screen?
Yes, we are. Maybe you can put it on slide share. Yes, we are.
Thank you very much. Yeah, thank you for the introduction, and Eric, Daktari, for a great presentation before me. And I think you've created a general background and most of the presentation for tonight. My role here is to come and just give you a more in-depth on mammography screening or diagnostic mammography. And I would be outlining and just bringing more depth in what is mammography, how is this technique done, what other imaging technologies do we use? And when we go to the guidelines, and some of which Dr. Eric has talked about, we will also look at breast cancer screening guideline in Kenya and the diagnostic mammography pathway. I shouldn't take long, but just to say that mammography, and this slide is coming to you again, is the mainstay of imaging or screening of the breast. And we are saying that mammography is recommended method of screening for women in average risk population. When we talk of screening, we know that we are picking patients that do not have any lump yet, are asymptomatic. So this is the most sensitive tool we have to be able to pick this kind of women before they even know that they have breast cancer. The utility of mammography uses what we have, uses X-ray. So a mammogram is just a machine that uses low energy X-rays. That this is different from the other general type of X-ray we use for other imaging like chest X-rays, CT scans, which use higher energies. But for mammography, we use low energy. And as stated, that is the recommended energy levels for the breast imaging. We know that breasts are soft tissues, and therefore the application of these energies to be able to visualize lesions or masses within the breast. Typically, and as the Daktari said, we normally do two basic images, what we call the standardized views of the breast for the assessment of the breast lesion. These two views, we call them CC or cranial caudal view. It is a view of the breast with the image or the beam coming from the top to the bottom. That is a cranial caudal view. And then we have the medial lateral oblique. Just as in most imaging, we normally want to have two views of the same organ or of the same, if it's a limb, we always like to have a full view. So in this case, we have CC and MLO. There could be additional views depending on what these two views have shown us. And sometimes we do what we call a spot magnification, whereby we want to highlight the area we are suspecting to have a lesion, to look deeper, to be able to see what else or what is inside. Like sometimes you want to magnify very small lesions or calcifications within that area. You may use spot magnification, which just uses the two views, but you magnify the view. And then sometimes there's some imaging equipment that can give you tomography especially for dense breasts. Tomography gives us an option of having even a 3D view of the breast, but it's not typically available in most imaging machines. So we are good to have the CC and MLO, and also the spot magnification. So common applications of mammography, we have heard that there is what we have as screening mammography. So in screening mammography, you want to detect these lesions early enough when the patient is asymptomatic. And this is where you have most benefit for the breast cancer patients. And at this level, even they're able to be treated completely. If you're lucky enough to pick our patients at very early stage before they are symptomatic. Many of our cases, because you had doctors saying that our patients had picked stage 3, stage 4, you will find that we're actually dealing diagnostic mammograms. In this case, to image the breast, we are saying that you have identified a lesion. Maybe a patient has presented with some of the symptoms like Tari talked about it, that it's a lump or retraction of the breast, and you're trying to say, okay, let me look, just trying to differentiate whether it's actually cancer or is the lesion a benign lesion. So that is now called a diagnostic mammogram. Sometimes you may do a surveillance mammogram. For the surveillance, you are assessing recurrence of malignancy with women with known breast cancer. So in this case, somebody, maybe you did a bilateral mammogram and found a lesion in one breast. You would want to do follow-up studies to see how the same lesion is doing, or even the other lesion, because a fraction of patients do develop breast cancer in the other breast. So it's always important to do a surveillance mammogram in patients who are under care. And then there is a needle localization and tumor marking. This is just in-house, done at radiology also, to be able to help the pathologist or even the radiologist to pick up lesions, especially really small ones that you cannot see. So you want to localize it and you put a marker of a needle and then you do an image so that as they go for biopsy, then someone, or even if they are going for surgery for a lumpectomy, then they're able to outline where this lesion is. Remember, if the patient was asymptomatic, the lesion may have been really tiny and it can be lost when the surgeon wants to intervene. Typically, what are the indications for a breast mammogram? So those ones that I've talked about were their utilizations, but mostly is for screening, as I've mentioned, is for diagnostics, when you have a mass or when a personal history of breast cancer, that is the surveillance, and also for localization. This is almost like a repeat. But the last bullet there is just to state that in men, we also, who are suspected to have breast cancer, we also do a mammogram. Men, we know that there are about 1% of the breast cancers are in men. We know that the only way we can tell is by doing a mammogram. Are there some contraindications? When don't we need to do a mammogram? So the contraindication is, we are telling you that there is no absolute contraindication. So we have to gauge the situation at hand, especially if we are saying that a pregnant woman presents to you, we are using radiation. Sometimes we have to weigh whether this lady will benefit from the mammography. Maybe you had a lump. The doctor may consider using other modalities of imaging before using a mammogram. But where there's high index of suspicion, yes, we've been able to do mammograms in pregnancy. In patients who are younger, you saw the cutoff age when we were saying 35 years and younger. We get very poor yield on breast mammography, and therefore we recommend other modes of management or imaging, like the ultrasound machine or the MRI that we can use for dense breasts to be able to outline for us better the lesions that we are suspecting to be cancerous. So if we go into the technique of mammography, this is just trying to explain those views. Mammography is done, of course, is the imaging of the breasts. We image one breast at a time, but the target is to have both breasts imaged, each breast receiving 2 views or 2 images. So what you're seeing there is a plate, a breast that is between 2 plates, and a camera on the upper side which will receive the radiation beam, and an X-ray is passed through the breast. At the end of the day, you will have an image. So this view, the way it is positioned like that, is the craniocaudal view. And the image that you will see will be called a CC image or a CC view. This is how the other images, I should have shown it, but you can see that in this case, we are seeing an axilla. The top side, you are seeing part of the armpit for this patient, and you are seeing at the bottom there an outline of the breast, up to the upper side, the armpit and the shoulder. This is the medial lateral view or oblique, of which is the other view of the breast, and it is normally compared very well with the CC view. And this is how the CC view looks like if you were to do it looking from above. So these images, these are now the outcome of those 2 techniques we have done. So here it's showing, actually, these are 4 images. I hope you're able to see 4. I hope you can differentiate 4A, B, C, D. So we have put A and B together to be able to give you the right and the left breast. And on the other side also, we have put C and D together to give you the MLO positions of the right and the left breast. So a very good mammo image, even for someone who does not, is not a radiologist, you'd be able to see something like this at very good symmetry, unless there is abnormality. And you're able to see different layers. As Dr. said, we look from the skin, then there are subcutaneous areas, then the tissues, and these dense areas in the middle, this is the muscle planes that harbor some, if you look at some densities there, is where we find the lymph nodes. So most views will be, most of the images of the women will be imaged in those 4 views or 2 views per breast. In cases like now this one, it may be different, but it is the similar views. You can see 4 views laid next to each other for comparison, and that is the typical way we look at these images. And we are looking for many things. We're looking for asymmetries, we're looking for masses in these breasts, and we're also looking if there are any calcifications, abnormalities, tissues that are running in an abnormal direction. Yeah. In this view, it is, you can see it is a bit more magnified, not looking, you cannot see the full breast. This is a magnified view. And in the center, you can see a very regular opacity, or which is a mass. And this is a cancer. If you can see on the left side, there is irregular, like the plane is not very straight. The contour has been distorted, which gives us as radiologists an indication that there is traction, which is highly suspicious of malignancy. So those are some of the signs we look for when we are looking for to differentiate between benign and malignant masses. So the same happens for this other view, and we are saying that this is a case of a 7-year-old female who was having a palpable finding in the right breast. And we are having 2 views of the right breast, CC and MLO. And the view demonstrates a 5-centimeter irregular mass. You can see the mass there, it's irregular, it's just below the skin on 1A there, on the CC view. And it's in the upper outer quadrant. So in the report, normally we would love to tell you the position of the mass, what it contains, the approximate size, and as I go further, I'll be able to also give it a score. Now, we have types of mammograms. Dr. alluded to some of these, that in the past, where we had what we're calling an analog, the extreme left is an image of an analog mammogram. an analog, was just the technology was analog. We're not using digital receptors. So therefore you can see that the image is less clear compared to the middle one, which is using a digital mammogram machine. Most of the equipment, I think, that are supplied in our county and sub-county hospitals are digital. Luckily, we know that they are helpful in trying to pick these lesions earlier. And on the extreme right, we have what is a tomosynthesis. And this is just been done on a digital machine to try and clearly outline the lesion. And you can see the edges, you're able to see them much better. So in short, that in the range of mammography, this is just the developmental, how technology has developed, but we're able to currently use digital mammograms. And if you have analog ones, they can still be useful, but you have to be careful to note that you really have to get very good quality images when you're doing the mammogram. Are there risks when we are doing mammography? We know that this is an X-ray, and you can see that we have recommendations on how we utilize mammography. But the risks we're saying are actually in the utility, that if you get a false negative result, this will give you a false sense of security that may delay the diagnosis, and that can happen. And also, sometimes you can get a false positive result. And this may, of course, give you associated anxiety. And sometimes if you get a very enthusiastic surgeon, you can lose a breast, because of the false positive result. So that's why we insist on these images being done the right way with a qualified and experienced radiologist being able to read them to minimize the risk of giving you a false negative or a false positive result. And of course, when we are doing this imaging, we put all the clinical picture in mind, and we utilize even other tools when we are not careful. When we are not sure, you're able to utilize other tools like ultrasound and MRI to be able to clarify the status of the lesion. So as mentioned, there are other detection technologies. Dr. mentioned the breast self-exam and the clinical breast exam, and we've seen where they have been utilized. They have been useful. We've seen patients that have been able to feel their own breasts and pick up a lump, and this is quite useful if they do it the right way. But for screening, we sometimes also use ultrasound and MRI. Now, these ones, for example, ultrasound, we know that ultrasound is a very commonly available tool, and it is also does not use radiation, and it has been found to be useful, especially in the young women who are where we have very low pickup, those was below 35 years and whose breasts are still young. You don't want to continually expose them to radiation. So we use ultrasound. It's very useful, just like in other parts of the body, to give us the locality, the size, even the content of what is in the breast, especially when you can feel a mass. It may not be useful in picking asymptomatic or breast screening where there is no lesion. So in the Kenyan guidelines, we do have recommendations of how we're using ultrasound. And we're saying for young women who are 35 to 39 years, we can complement them with ultrasound, especially where we're not sure we want to directly do mammography. And we can use that with a clinical breast exam. We can also use ultrasound for image-guided biopsy. You've seen a lesion, you've done, you can pick it, you want to take a core biopsy, then you'll use ultrasound to guide you. And it's very useful in most of the core biopsy, as core biopsies that are done. Then we can also identify the nature of the lesion, as I've said, what type of lesion we are having, and even to do follow-up of some of our patients. Now, MRI, we know that MRI is another high-end diagnostic tool. It's not cheap, but it's very useful for high-risk populations. Patients who have a high history of cancer in the family, they are young, we are having queries, is there cancer, no cancer? And then you would have to subject them to MRI to be able to pick these cancers and differentiate tumors or cancerous lesions from the benign lesions. But it's not recommended for routine screening of the average population. Of course, it's not cost effective in doing it that way. And that's mainly the core reason why that is not recommended. Its role, if you just to say the additional role of MRI, is to say that, as Dr. mentioned, is for staging and surgical planning in breast cancer cases. It is also for searching primary tumors where some patients have presented with nodes and you cannot find the primary, and to also evaluate tumor response when someone has undergone neoadjuvant chemotherapy. Because a mammogram would not be very good in this. Sometimes there is reaction around the breast, there's been surgery on that breast, so you really want to see if you want to pick up a new lesion, MRI would be better. Then you want to differentiate tumor recurrence from post-surgical or radiation changes. That's what I just mentioned. And screen high-risk patients who are less than 35 years, and then also to evaluate breast implants. So an MRI would appear like images like this. Of course, this is an image on an axial view of one breast. We normally have two typical images again, but it's the weighting that we use, a T1 or T2 weighted, and be able to pick lesions and evaluate them. Where you're seeing those masses there, one below the other one, you'll be able to pick up those lesions and evaluate them further. For both breasts in T1 and T2, this image here is just showing us it's a follow-up of a breast implant. And on one side, on the left, on one side, you can see a ruptured implant with some fluid or the implant leaking. And on the right side, you can see that there is a leakage or breakage of intracapsule rupture inside. So what are the guidelines in short telling us? This slide, we've already looked at it. We are saying that above 35 years, we expect that we will be doing a bilateral mammogram and or a complementary ultrasound. If someone is less than 35, we expect to do a bilateral breast ultrasound. And also, we may use this ultrasound for guided biopsy. Young women who are, and those at high risk, a breast MRI will be considered. Younger women and those at high risk, breast MRI will be considered. Now, all imaging studies must be accompanied by a report from a qualified radiologist. And we've also mentioned earlier through Eric that an FNA, there's a role of doing an FNA, but we have to be careful where we're using FNA. The recommendation is not to do, if you have a breast lump, you should not do an FNA, but unless you are looking for evaluating the lymph nodes, or you are looking at a nipple discharge or aspirating fluid from a simple cyst, which is a benign lesion. Triple assessment. So the gold standard we know of assessing a full evaluation of the breast is we need a clinical exam coupled with a bilateral breast imaging and a histopathology core biopsy. That should be the mantra of managing or assessing the breast patient. Always have a clinical exam, have a bilateral breast imaging, and histopathology. I think that should be the message on this slide. I need to talk in depth. Dr. mentioned about BRADs, but I need to talk a little more in depth on the meaning of all these BRAD classifications. You will see in the mammography and also in ultrasound reports that we like to classify the lesion or the pathology that has been found. And every radiologist's report, a comprehensive one, should have the BRAD classification. This also helps us for follow-up and to be able to know what interventions to do once we've seen some lesion. As he mentioned, the BRAD 0, in this case, we are not sure what we've seen. The mammogram or the ultrasound has not been useful, and you're thinking maybe you need another additional view. So you'll have a BRAD 0, and you'll recommend an additional view, depending whether you're saying additional views or different technologies. In the BRAD 1 cases, this case, you've done a mammogram, it's an annual screening, or even someone came up and you found it was negative. So what do you recommend? That you reassure the patient and you say you can come for another annual mammogram next year, provided they're falling within that age category. Then if you find that someone has a benign finding. Benign finding, there are classical examples or features of benign findings, and you're very sure, maybe it's a fibroadenoma, maybe it's a cyst. You're able to categorically either recommend management of that benign finding, and of course, you continually recommend the annual mammogram. Remember, the annual mammogram is for picking cancer. But if you found a benign lesion, it does not mean that now this patient is off screening. So they'll continue the annual mammography. So if you have a BRAD 3, in this case, we are saying, maybe something is here, it's probably benign, but this benign lesion doesn't look very inert. You want to do a short interval follow-up. So you may ask for a 6-month follow-up suggested with a bilateral mammography. So normally the radiologist should be able to discern the differences, whether it's a benign or a really probably benign finding. And then a suspicious abnormality, in this case, we're saying biopsy should be considered, and this will be done normally immediately. If you're lucky in the same setting or with the booking, then you're able to do a biopsy to be able to tell us, is this malignancy or not? Another case is that you will do an examination and really find the typical suggestive malignancy on the mammogram or on the ultrasound. And this also, you will say, biopsy should be done. And of course, the biopsy and pathology evaluation will be able to tell us what kind of cancer it is or whether it's a cancer, and be able to classify for us. The other one, which is a BRAD 6, we know that it's cases. We know sometimes that these are biopsy-proven carcinoma, and maybe you're just imaging sometimes to look at other features or looking for other lesions in the other breast. So that will be a BRAD 6 classification. So that's how the imaging is reported, and you should be expect such a report when you're reading those images or the reports. Let me give you an overview. I'm about to finish of the screening age and population, the guideline. And I know Dr. has mentioned about the 40 and above cases, but we normally, the National Cancer Control Program did a quite intense work and be able to give guidelines that between the age of 25 and 34 years, we know that 25 years, this is a reproductive age group, and that patients should start having the habit of having a clinical breast examination, that whenever you see these patients in the clinic, give them that benefit of having a CB at least once every 3 years or 1 to 3 years. And this age group, mammography is not recommended, okay? Unless stated, unless it's a high-risk patient. Then we have this age group of 35 to 39 years. In this age group, we continue to do a CBE, and at this point, you want to introduce slowly imaging. We recommend you introduce ultrasound. Sometimes mammography may be required if this is a high-risk patient or you feel like there's something suspicious. But these are the patients, again, you want to do CBE and ultrasound. This is done intervals of 1 to 3 years. And then at 40 to 55 years, you'll continue clinical breast exam and mammography. So this is the first time you're doing a categorical screening mammogram, and which is now, you can see the interval is annual mammogram. Then 56 to 74 years, we have reduced the interval to every 2 years, but you're also doing a CB and mammogram. Beyond 75, unless the patient prefers and they are okay, you can discuss and do the mammogram if required or not. So typically, these are the national guidelines. This is what everybody should put on their walls in the OPDs, in radiology, surgery, so that you're able to remind the patient and yourselves on when to do a mammogram and a CBE. On this slide, which Dr. attempted to walk us through, is going to just walk and see the decision levels, like if you find a breast lesion. Now, in this case, a patient has a lump and they have come for examination by an experienced clinician or a breast surgeon. So if the considerations will be made like this, that if this patient is less than 35, two things will happen. It will either be a simple cyst, or which is a benign lesion that will need aspiration and observation or follow-up after 6 weeks. If you look at on the extreme, extreme left on this side. Then if this lesion is in the category 1 and 2, and also there was category 3, you will have to repeat. If it was 1 and 2, you remember we said you'll do an annual mammogram. If it was a category 3, BRAD 3, you will have to repeat after 6 months. If this lesion now was a BRAD 4-5, that is a complex cyst or bloody, it has residual solid mass, then you will have to either do a core biopsy and go and see what it shows you. And of course, the core biopsy also has its own category, pathological category, whether it's benign, indeterminate, or malignant, and there'll be respective surgical intervention done. Either you're saying you refer to the surgeon, or they will remove the biopsy, the lump itself by excision biopsy, or you will excise the lump itself if it's benign. So on the other hand, if this patient was above 35 and they had, looking at the extreme right, and they had a level 1-2 or BRAD 1-2, you will also do annual mammography. If it's a BRAD 3, repeat after 6 months and observe, and you'll follow just like the other patient who was less than 35. But if they were also a BRAD 4-5, they will have a core biopsy done. The same pathway they will follow depending on the type of pathological report you receive, and the surgical intervention then will intervene or will ensue. So what have I said in short? So we are having a short message that screening increases early detection, it improves the prognosis, it reduces mortality of breast cancer. We are saying that mammography is the recommended screening method in women in the average age group who are the majority. And we're saying that ultrasound and clinical breast exam are not screening methods, but are useful for early diagnosis, and they can complement mammography. My MRI is maybe useful in younger women and in the high-risk group. So these are the key take-home messages that you need to get from this short presentation. Thank you very much for listening to me, and I would hand this back to our moderator. Thank you very much.
Thank you so much, Dr. Manduku. That was very detailed, and I thank you again for the nice summary. We have a take-home message where, in case you miss something, the take-home message is there. Just do your part wherever you are. This session is coordinated by the Ministry of Health. This webinar is coordinated by the Ministry of Health under the National Cancer Control Program, and we are privileged to have one of them, Dr. Hannah Kitungo, who is a program officer at the National Cancer Control Program, and she works under Pillar 2, which is concerned with diagnosis, registration, and surveillance. So Hannah, welcome. Give us a brief on what you have for us, and I'll request that we make it very brief because we're running out of time, so that we'll have some time for question and answers. Karibu. Dr. Hannah, please go ahead.
Can you see my screen?
Not yet.
Okay. Can you see it now?
Yes.
Okay. So as you have said, my name is Hannah Gitungo. I'm working at the National Cancer Control Program as a program officer in Pillar 2. Pillar 2 deals with diagnostic, registration, and surveillance. So I'm going to take you through breast cancer data collection, and reporting. I have an outline. I'll do the introduction. We have the breast cancer burden, the national screening guidelines, monitoring and evaluation, breast cancer screening indicators, and then we have data tools and some ways on how we are going to improve the data. So cancer data is important with the cancer control continuum of care as it helps to provide cancer disease burden. It also informs policy change. It guides resource allocation and also helps to generate research hypotheses to guide necessary policy action that are to be taken by the ministry or any other situation that we have that need to have those guidelines. Now, we have the cancer burden according to Global CAN. Global CAN is a repository of cancer data globally. And when we look at this graph, we can see breast cancer is leading in terms of incidence, and also in mortality, you can see we are losing almost half of the patients that we see. My colleagues earlier took us through, and in the year 2018, we had 5985 new cases of breast cancer. And by the year 2020, this number has risen up to around 6799. So it's a concern because we are seeing a rising trend in the breast cancer burden. My colleague, the two colleagues that have been there before, have taken us through this. I'm not going to dwell on this because we have just been taken through, but these are the guidelines that she was talking about, the National Cancer Screening Guidelines that have been developed in 2018, and they are in use. And these guidelines are online in the Ministry of Health website. So you can refer to them and see the various methods that you're supposed to use while doing the cancer screening in your various levels. When we talk about monitoring and evaluation in cancer, monitoring is a continuous process towards assuring and improving the quality of screening. As we have seen, screening is quite key in whatever we do in our various levels. We are doing breast cancer screening, we are doing cervical cancer screening, we are doing also colorectal cancer screening in our facilities. So we are doing monitoring of this to see how we are performing as a country, and is giving us quite some information. Evaluation is done periodically to inform the systematic review of program indicators and targets. We have targets that we have put, and I can tell people that are in this forum that we are not doing very well in terms of breast cancer screening. I think we are less than 10%, which is quite wanting in our country. Our breast cancer screening programs need a responsive information system that can provide evidence to inform actionable decision, leading to desirable patient outcome. So we need to do all this so that we can be able to have good outcomes that can make actionable decision at various levels in our country. This one, the continuous proactive monitoring will also help us in using quality improvement tools that we have in the Ministry of Health, in the Health Information System, and this will enhance program efficiency and effectiveness. I'm going quite fast because I know we have another presenter that is going to present after me. Then we have the components of effective quality assurance. When we talk of quality assurance, we refer to an overall management system that guarantees the provision of good quality. Effective quality assurance, we have indicators, and when we talk of indicators, they need to be measurable and clearly defined. And they facilitate assessment of the program performance towards achieving the goals and the targets that have been set and the goals that we need to achieve. We have the data, the service data collected at facility level. We have data being collected at all levels, from the lowest level to the highest level. They are aggregated and compiled and forwarded to the Kenya Health Information System. We also have standards. In these standards, I showed you earlier, we have the national guidelines, screening guidelines. We have trainings that we do countrywide, and they are done according to the standards that have been laid by the National Cancer Control Program nationally. We have some breast cancer screening indicators that we need to monitor. We have the screening coverage. When we talk of the screening coverage, we talk of the percentage of women screened as a proportion of the eligible women within a given period. When we talk of the positivity rate, we talk of the number of women with who screen positive in a given population, and their biopsy rate. When we talk of that, we talk of the proportion of ultrasound-guided biopsies, as my colleagues have taken us through, performed out of those eligible. When we talk of the tools that we have in the ministry to capture this data, we have the cancer screening register. In the tools that we have for the Ministry of Health, they are usually given a Ministry of Health number. So for the cancer screening register, it's called MOH412. This screening register comprises of breast cancer screening and also colorectal cancer screening. This is a primary data collection tool. When the data is collected, the data is summarized at a ministry tool called the MOH745 that is summarized at the end of the month, and the data is fed into the Kenya Health System. When the patient comes for screening, they are given a card for them to remind them of their next appointment. And it's also a reporting card in the ministry. We have the commodity dispensing reporting tool. This tool is used to report the pharmaceutical commodities that are given to the cancer centers. They have the beginning so that we know in certain region, we know they're having this type of drugs, and we know when they're expiring. And if another county is also in need, there is a way we track them to make sure that all those that are in need are given what is there, because there are some that we sometimes find they have surplus and others are missing. We have the treatment register, as my colleagues have just taken us through. When we have these positive cases, when we are known to be a positive breast cancer patient, now we refer you to the cancer center where further management is taken. And when this management is being done, or what the client is being taken through, the regimes that the client is given, they are recorded, all this is recorded in this register that is called the treatment register. These are the tools that I was talking about when I talk about the cancer screening register. And in this is where you have the breast cancer screening. Before, you never use somewhere we never used to document breast cancer screening anywhere, but nowadays we are doing so. And that is why the uptake is key now, because we can be able to monitor what is happening. And this is the tool I was talking about, the KNH-745, that we summarize all what we have received from the primary register to the KNH-745. This is the screening card that the client is given after she visits our facility for those services. We have the SOPs that we use in those primary registers. As you can see them, we have columns and what we are supposed to fill in those columns, which are quite key. These documents need to be clearly displayed in those service delivery points. As my colleague said earlier, sometimes you find those positive, false positives, and the only way you can be able to tell this is using these documents that have been provided by the ministry. So those are the screening SOPs that are provided in the register. These are where the documentation of a client is done. We have the age of the client, you have the next of kin, then you have the BIRATs that Dr. has just talked about from 0 to 6. The BIRATs are a quality assurance tool that is used in mammography. And when a client is seen, the results are documented here according to what has been found in regard to that particular client. They are coded, and this is how the analysis is done, and we can be able to tell now how many of our clients have been found to be having breast cancer. So that is a tool that is used, and we summarize these findings at the end of the register. At every end of a page, we do a page summary, and this page summary is the one that is translated at the end of the month to the KNH-745 that is also forwarded to the Ministry of Health headquarters. So those are also, that is the summary tool that I'm talking about. It has the age cohort, the clinical breast examination that has been done, whether it was normal, whether it was abnormal. So we can be able to tell in a particular county the number of CBs that were done and how many of the breasts were found to be abnormal. Yeah, there are also the age cohorts, as I've said, the BIRATs and the mammogram that have been done. We can be able to tell, and the age cohort that is being affected most through this summary, we can be able to tell that. This is the register I talked about, that after one being found to be having cancer, you are now transferred to a cancer center for further management. And this is the tool that we use in the cancer center. And this is where you can find our data for the people that are having cancer in the country. So those are the SOPs, and where you can feel a particular client is, each client is supposed to occupy one line, all her details or his details. But here we are talking about breast cancer, which affect female, but there is that 1% that affects men, as we see according to the data that we have. This is the commodity tool that we use for dispensing the drugs that we have. Those are the instructions that we have and how you are supposed to fill that primary data collection tool. And these are the drugs that are there. You can be told, you can be able to tell what you had at the beginning of the month and also what you have at the end of the month. And we can be able to tell the type of drugs that are not available in a particular health facility, and the particular facility that have excess of a particular drug. So this is the tool that we use. Those are still the drugs that we have in our facilities. So when we come to the data capture, the data registers are usually stationed at a specific point of service delivery point designated by the facility. So it's a facility to say where these tools are going to be stationed, and it varies from one facility to the other. Like for the cancer screening register, we usually find it at MCH, the comprehensive care center, the patient department for cancer screening, and also breast cancer screening. The 273 are usually found in the cancer centers, and 646, that is a tool that is usually at the pharmacy. The health worker in charge at a specific service delivery point is responsible for filling in the daily activity register. And one key important thing is that it is important to always fill all the required variables in that registers, because they are key when we are doing the analysis. And when we find some missing information, it becomes quite impossible for us to make a proper decision in regard to the data that we get from these data tools. What are some of the common problems that we have? Lack of training is one of them. So training, we find that quite a number of our health workers lack training. The data reviews, when we do these data reviews, and is when you can be able to tell the gaps that we have. And some of these reviews are not done quite well in a number of health delivery levels. We also lack those registers and summaries, the data collection and reporting tools. Sometimes they are not enough, and they make us also not get data in good time. Late reporting. There's a deadline that we are given from the Kenya Health Information System that all the data for the previous month are supposed to have been reported by 15th of the next month. So we find quite a number of facilities are reporting late, and these make us make decisions that are not data. The data that we make usually when we have these late reports make us not make proper decision. The non-reporting, we have some facilities, especially the private ones that don't report to us well. So non-reporting also affects our data. Facility data ownership, sometimes when we get this data and maybe we want to clarify maybe some figures that we found that are not sometimes making sense. When you call maybe a particular facility or a particular county, sometimes when there is a problem, there is no ownership of that data. So those are some of the problems that we do face in regard to data. How are we going to improve this? The way we are going to improve this as health workers who are in this forum, we sensitize and train healthcare workers on data collection and reporting so that a proper decision can be made. We also need to avail the necessary data recording and reporting tools at all levels. Ensure the reporting to KNH-UoN is done on monthly basis. So by 15th of every month, we make sure that we report this data so that decision can be made in good time. We need also to consume the data at every level for decision making. So we should not always forward the data to the national level. we need to consume this data at our service delivery points so that also proper decision can be made at those lower levels. We should also conduct regular data reviews so that we address the gaps in good time. And when we address these gaps in good time, we are going also to inform the country in good time on the action that need to be taken in regard to the breast cancer interventions that need to be taken. We say teamwork is key in data management. Data management involves all of us. That's why here we are, all cadres are involved. We need to work as a teamwork, because if let's say a request has gone to the lab, you have done the biopsy, it's not recorded anywhere, you are disadvantaging that client because maybe he or she needs to be done something, and if it's not documented, the next maybe doctor or the other practitioner who is going to see that patient won't have enough information to make a proper decision in regard to that client. So points to remember: accurate and timely data capture in the proper MOH data tools. As I said, these are standardized data tools that are used by the ministry, and we need to take care of them. Migration to MOH 711 or cervical cancer reporting to 745. Before, the health workers were reporting this data in a tool called Integrated 711, but this has been moved to MOH 745 because this 711 never used to have the breast part in it, but now we have 745 that incorporated the breast screening in it. We should also, as health workers, know the targets that we are working towards and track the progress as you work towards achieving them. And also, you make sure that we are also evaluating what we have in regard to the activities that we have planned to do. Maybe we have planned to do a mobile, maybe screening. Like now we have the breast cancer month, you need to have those mobile clinics. You make sure that you collect all that data that you have done so that we are able to capture, if you have any suspicious case, we are able to capture them in good time. You also need to consume and utilize the data in critical decision-making areas so that this one can help in all this we are doing in regard to the client so that proper decision can be made in regard to management of this particular client. So teamwork, as I said, is quite key in data management, and we need to document well so that also the people who are supposed to analyze are supposed to give us proper data or proper information that can inform the country in what is supposed to be done in regard to breast cancer in this country. So thank you so much, and back to.
Thank you so much, Dr. Hannah. Indeed, we have a lot of work to do. We have a lot of, our role is to create awareness as well as make sure that we document our findings. And that is, I think, one of the take homes today. We need to document and document in the proper tools. Time is far gone, and I'm sure people are already saturated, but I'll ask Dr. Hungu to maybe answer one or two brief questions which have become common. And if there's any other burning questions, please let me know. I can see most of them have been answered on the wall, on the Q&A wall, and some of them were answered even online during the presentations. So Dr. Hungu, please take it over as we briefly so that we can summarize.
Thank you, Julie. So I'll just touch on two questions. So I've seen a few people have asked about cysts, small lumps, and the need for biopsy. And I've seen Dr. Manduku has answered one. So just to further clarify, when we are talking about triple assessment, your findings need to be aligned so that if you do a clinical examination and the lumps feel suspicious, and then you do imaging and the imaging says that the lump looks suspicious, and then you send for biopsy and the biopsy says it's benign, then perhaps you might need to consider doing a repeat biopsy or getting a second opinion from another lab. Same thing with imaging. If you have clinical examination that looks highly suspicious and then imaging comes back and says conclusively that it's benign, or they can't make a decision, then perhaps you need to escalate, either do a tomogram or an MRI just to further get an imaging diagnosis. Now, on the issue of cyst, imaging again should also tell you whether this is a simple cyst or a complex cyst. If it's a simple cyst, depending on the size and whether it has symptoms, if it's a big cyst, sometimes they present with some pain. So aspiration is usually adequate for both therapeutic and diagnostic. If it's a complex cyst, then it's recommended that you do an ultrasound guided biopsy of the solid bits, because sometimes you find that that solid part might actually be malignant or a pre-malignant lesion like a carcinoma in situ. So again, all these patients, it's always safe to, if you're not sure, it's always safe to just do triple assessment, do an FNA at the minimum. If you're able to do a core biopsy, get a core biopsy. There was another question that was asked about the role of alcohol as a risk factor. So that is a question that requires a very comprehensive answer, but just to summarize, it's been theorized and there have been some studies done that postulate that perhaps the role of alcohol in causing breast cancer might arise from the metabolites, so that when the ethanol is broken down to acetaldehyde, then it's found to be carcinogenic. And sometimes increased consumption of alcohol has also been associated with an increase in estrogen. And as has been documented, estrogen is a known risk factor for developing breast cancer. But this is a topic that requires maybe like 30 minutes or an hour, and a geneticist and a biochemist. But that's just the broad answer to that. I think those are the burning questions, Julie, and the common ones. Yeah.
Thank you, Doc. There was one very early question where they were asking, is there a gene therapy for treatment of breast cancer? I don't know whether you can maybe give us a light.
I've not heard about gene therapy. All I know is that you can do some genetic assessment to know whether you have the mutation. The common one assessed is the BRCA1 and 2 genes. And if the mutation is found, then there's prophylactic surgery. But I've not heard about gene or interventions at the genetic level.
Okay, thank you so much, Dr. Hungu. I think we have come to the end of our webinar this evening. Unfortunately, time is far gone. I can see most of the participants have dropped out. But I want to take this opportunity to thank our panelists, our presenters, our speakers this evening, Dr. Veronica Manduku, Dr. Eric Hungu, and Hannah Getugo. We really appreciate you for taking your time to prepare, to come and give us the very important information you have given us, especially during this Breast Cancer Awareness Month. I believe we all have learned something as participants, and I also want to thank you for logging in and even being patient until the very end. Now, for those who are sending their emails for CPD, the CPDs will be communicated as per the email you used to register. So there's nobody who will be sent a CPD individually. The email you used to register for this webinar will be used to send your CPD, more so for those who are given the code. So please be patient. You will get a communication from the KNH research team so that they can update you. And then all the webinars are recorded. So for the slides, you can review them in the website, the KNH website, so that you're able to see the slides and to listen in to the recordings. It's actually uploaded on the screen. That is a website where you can find all the information about this webinar. But for now, I think that is all we have. And I want to wish everybody a good night. Keep your patients educated, give them all the information they need to know, more so concerning screening, so that we fight this battle and get early detection and prompt treatment. From me, it is good night and God bless you.
Thanks, Julie.
Thank you. Thank you very much. Good night.
Good night.
Thank you and good night. Good night. Oh.